Top-Bed Talk.
This is the Ernest Henry Starling Plenary Lecture, a lecture we've had as a named plenary for a number of years now, and it's one that we reserve for our most special guests and people who've really made an impact in the field of perioperative medicine, and in particular evidence-based perioperative medicine. So the lecture is named after Ernest Henry Starling. He was an alumnus of University College London, where all of the three originators of this meeting were working at the time, so we named it after one of our greats. And Starling you will know well as a legend of physiology, but much physiology that has underpinned perioperative medicine, so physiology of fluids, of the heart, and of endocrinology. I think it's very appropriate that this year we have a very eminent cardiologist giving us Ernest Henry Starling lecture. And it's a pleasure to introduce PJ from where he is in Canada. The CV is long, and you'll very quickly realise the reasons that we've invited PJ. He's currently the director of the Division of Cardiology at McMaster. He is scientific leader of the Anesthesiology, Perioperative Medicine and Surgical Research Group at the Population Health Research Institute. And he's a professor and university scholar within the Departments of Health Research, Evidence and Impact, and Medicine at McMaster University, where he obtained both his MD and his PhD. I could talk for a considerable amount of time about PJ's impact on perioperative medicine. I think the two things that are most notable is that he has been very generous and open in reaching out beyond his specialty of cardiology, and is a really great interdisciplinary collaborative worker. And I think that's been to the benefit of all of us, and hopefully it's been to the benefit of him as well. And the other thing about PJ is, in common with very, very few people in perioperative medicine, you can simply list his studies and people know who you're talking about. So you may not know that he's the author of them, but if we look at vision, cardiac vision, poised to manage, hip attack that we're going to hear about a bit more tomorrow, the list is long. So you can see why we've invited PJ to be our Ernest Henry Starling lecturer this year. It's a delight to have you, at least virtually in person, PJ. Thank you very much. Really looking forward to your lecture.
Hi, my name is Dr. PJ Devereaux. I'm a cardiologist and perioperative care physician and epidemiologist at McMaster University. Delighted to be with you here today to give this lecture. I want to thank Mike Grocott for the invitation. I really appreciate the efforts everyone's making during this time of COVID to allow us to continue to share our knowledge, and I look forward to hearing a lot of the other lectures in this conference. So today I'm going to be talking to you about a new paradigm to improve the safety of major complications. I'm expected as part of our university policy to put up my disclosures at the start of all my talks. If you heard my talk earlier in this conference, unfortunately, there's been no new conflicts. They remain the same, but I'm a member of a research group which has a policy of not accepting honorariums or direct payment from industry for our own personal financial gain. We will, however, take money from industry to support research endeavors. And based on study questions I've originated in grants I've written, I've received grants from many different companies. What's most relevant is that I will get into talking about remote automated monitoring technology, and we have received some support from Philips and CloudDX. The goals of my presentation are to understand when and where surgical complications occur, to learn the historical perspective of major paradigm shifts that have occurred to improve surgical safety, to gain insights into potential next paradigm shift that I think may happen within the surgical setting, and also to become informed about a new division of perioperative care that we've initiated at McMaster University. I'll start off with a case. So this was an 83-year-old female who had a history of hypertension, had a 20-pack year history of smoking, but had stopped smoking 30 years previously. This patient had no known history of coronary artery disease, cerebral vascular disease, or peripheral arterial disease. This patient's ejection fraction was 60%, and this patient had erectovaginal fistula. This patient took their candesartan, which was their normal antihypertensive medication, 8 milligrams on the morning of surgery. And on February 7th, this patient underwent a lower anterior resection, a loop ileostomy, and a vaginal wall resection. The surgery was a late-day case. It went from 1825 to 2200 at night. Intraoperatively, the systolic blood pressure was 80 for 10 minutes and 90 for 20 minutes, which from my observations of looking at lots of intraoperative hemodynamics from all of our studies, very unremarkable intraoperative hemodynamics. Postoperatively, the patient had an epidural for analgesic control and an IV running at 125 cc's an hour. The patient arrived on the surgical floor on February 7th at 2300 hours. At that time, their heart rate and blood pressure was recorded, and the heart rate was 91, and the BP was 110 on 55. The next time that the vitals would be checked would be on the 8th at 4 a.m., so 5 hours later. And 5 hours later, the heart rate is 84, and the blood pressure is now 78 on 40. The surgery resident is called, and the surgery resident has just started a case in the OR and orders 500 cc's of normal saline bolus. The next time the vitals are noted to be checked again is 6:30 in the morning. The heart rate is now 76 and the BP is now 70 on 38. The surgery resident is called. The surgery resident orders some blood work and says that they will be up as soon as they're done in the OR. The surgery resident arrives around 8 in the morning. The heart rate is 80, the BP is 75 on 36, the hemoglobin is 94. The surgery resident orders 1 unit of packed red blood cells and orders an ECG. This is the patient's preoperative ECG, which is relatively unremarkable, minor criteria for LVH, QS pattern V1, but nothing very dramatic on this ECG. When we get the ECG that the patient has on the morning of February 8th, we now see that there is a QS pattern in V1, V2. We see clear, significant ST depression in V3 through to V6. We also see some ST depression in lead 2, and we see some ST elevation in AVR. Very concerning ECG for potentially a high-risk lesion. At 10:30 on February 8th, the patient's systolic blood pressure is now 60. A code is called. We end up seeing this patient. We admit the patient to the CCU. We give inotropes and fluids. The BP normalizes. The patient's troponins, not surprisingly, are elevated. The next day, on February the 9th, the patient has 20 minutes of chest discomfort. We take them to the cath lab. The patient has an 85% mid-LAD lesion, and the patient has a stent, and the patient does okay. Now, it is good news the patient did okay, but I hope that everyone would recognize in this case that obviously it could have went in a very different direction. Moreover, it seems very clear that we were very delayed in recognizing when in fact the patient had become hypotensive, and moreover, we were also delayed in actually responding to this and correcting it. In looking at surgical complications, globally there's over 230 million adults who are having major surgery annually. In the Vision study, which was a prospective cohort study of patients aged 45 or greater, 28 centers in 14 countries who underwent inpatient non-cardiac surgery, and in Vision we demonstrated that 1.8% of the patients died within a 30-day period. If we look at the timing and place of where people died, death in the OR was exceedingly uncommon. Only 5 of the deaths, that is 0.7% of the deaths, occurred in the OR, whereas 500 deaths and 70% of the deaths occurred in the hospital after surgery. Importantly, 210 deaths, that is 29% of the deaths, occurred after patients were discharged home. Importantly, 6% of these patients were also readmitted to a hospital within a 30-day period. If we then look at all of the complications that happen after surgery, and in risk-adjusted models also adjusting for baseline clinical factors and the type of surgery, we demonstrate that these complications on this slide were the ones that were independently associated with 30-day mortality. Now, the way that this slide is set up is that the first column tells you the major complication that happened after surgery. The second column shows you the percentage of patients who died with this complication. And the next slide shows you the adjusted hazard ratio. And the final column shows you the attributable fraction. The attributable fraction is basically informing you if in fact this is a causal path to actual mortality, if in fact you prevented those complications, what percentage of the deaths you would actually avoid. And what we see is that there was 3 main complications that accounted or was most strongly associated from a attributable fraction point of view with 30-day mortality. And these were major bleeding, myocardial injury after non-cardiac surgery, MINS, and sepsis. And these had attributable fractions of 17, 16, and 12% respectively. Also of note, when you look at things like venous thromboembolism, you don't want to have it because your risk of death, the adjusted hazard ratio, is statistically significant. It's over a twofold increase in the likelihood of death. However, the reality is VTE only has an attributable fraction of 0.3%. And that's because VTE is so uncommon in today's world after surgery relative to things like major bleeding, MINS, and sepsis. VTE accounts for very few of the actual deaths. And if you look just at VTE compared to even just sepsis, it's a 40-fold difference in the probability of accounting for the number of people that are dying in the first 30 days after surgery. And looking from an historical perspective, surgical research has overwhelmingly focused on the intraoperative period. And I think it is very important to acknowledge that within individual types of surgeries, there have been major advances in surgical techniques that have had major improvements for patients with those specific surgical indications. When we look at a global level, though, of overall surgery, I would put forward to you from my reading of many historical textbooks on surgery and anesthesia, I think that so far in the history of surgery, there's so far been two paradigm shifts that have substantially improved surgical outcomes for all types of surgery. And the first really came into being recognized in the 1840s, and this was the identification of the sterile technique. Now, at that time, what is fascinating about this story is that germ theory was still not established at this time. But there was many people, and Joseph Lister was one of the key individuals in this area, who recognized the entity of sepsis. They thought it was inflammation, but they recognized that some patients after surgery had these red, pussy wounds, and patients became febrile and had a high probability of death. Now, at the time, because there wasn't anesthetics, surgeons had to be incredibly fast. So the mark of a great surgeon was someone who could perform surgery in a very short period of time. And as a result of that, what would often be the case is that surgeons would be in the anatomy lab working with a cadaver to rehearse the surgery, and then would come directly from the anatomy lab into the OR and perform the surgery. And because germ theory still wasn't established, no one was washing their hands, no one was changing their clothes, they were just going in and performing the surgery, and this meant for a very high probability of passing on bacteria to the patients, and once again, these high levels of infection and sepsis. Joseph Lister, who was a friend of Louis Pasteur, was fixated on this issue of sepsis. He was one of the people at the forefront of thinking that perhaps they were taking something from the anatomy lab into the ORs, and then was one of the first people to get into hand washing, changing of clothes. And this whole sterile technique movement had an enormous impact, ultimately culminating even in antibiotics being given prophylactically around the time of surgery. But even at the time of just changing clothes and washing hands, we saw surgical mortality drop from 46% to 15%. I would put forward to you that the second paradigm shift that dramatically improved the safety for all surgical interventions was anesthesiology. Interestingly enough, the story of the sterile technique and anesthesiology are directly linked. As I mentioned, one of the things that made surgery so much higher risk is because surgery had to be so fast, people would rehearse and then come right into the OR because there wasn't the ability to control patients' pain. Also in the 1840s, we had the introduction of anesthetics, and that ended up being a very important game changer too. And what we see is that in the last 100 years, we've had a dramatic shift in the probability of intraoperative deaths due to anesthetics. So 100 years ago, research supports that about 1 in 1,500 patients died from an anesthetic complication. Importantly, 100 years ago, surgery was mainly performed on young people with very little comorbidity. What's remarkable is that in 2015, research supports that 1 in 200,000 patients die from anesthetic complications, despite the fact that in today's world, we primarily do surgery on older patients with lots of comorbidity. This is a startling advance within an area, and the question becomes is how did it happen? Well, like most things, I think it's multifactorial, but I will offer my perspective on how I think this happened. I think that the big advance with anesthesiology was that there was a physician now in the OR who was dedicated and present and responsible for the patient's physiological stability. And secondly, over the last, especially 30 years, they have enhanced intraoperative monitoring. Obviously, patients having anesthetic, especially general anesthetic, can't communicate with us to tell us that they are in trouble. And even if they're getting regional anesthesia, they may have blocks which will impede our recognition that, in fact, there is a problem. And so the monitoring ended up being very important. Now, some people will say, where are the large trials showing that intraoperative monitoring has changed outcomes in a dramatic way? And they're not there. However, I would put forward to you that it is for certain that they have. And the easiest litmus test to understand this is that, is there any anesthesiologists in the world today who would personally undergo a major intraoperative surgery and tell the anesthetist to turn off the monitors and simply use the force? No one in their rational mind would do this. And the reason is every anesthesiologist has had cases where, in fact, substantial physiological abnormalities were detected through the monitors that they did not instantly appreciate clinically. What is the reality of postoperative care? In hospital, patients usually receive their care from their surgeons. And the reality is surgeons are busy and surgeons are frequently doing what they love doing, which is doing more surgeries. And as I demonstrated in the case that I spoke about earlier, the surgical resident cared about the patient, but the surgery resident was disposed doing another case, which limited them from getting to the floor to actually respond to the patient. And after discharge, patients are typically seen by their surgeon between 2 and 8 weeks after surgery, and they may see a family doctor sometime in between there. What is the reality of monitoring in our perioperative care setting? Well, a very small minority of patients end up going to the intensive care unit, so the vast majority of people are managed on surgical floors. And on surgical floors, it will vary, but in general, in most hospitals, certainly in our research, patients are having their vitals checked every 4 to 8 hours. And if you're at 4 hours, you're in a very fortunate situation because most are at least 6 hours. We're doing this monitoring this infrequently in patients who've just had anesthesia and are invariably getting analgesic medication that can mask their ability to identify complications. And after patients are discharged home, overwhelmingly patients have no monitoring until they're seen in their follow-up clinics. Suboptimal monitoring, and I'll look at the case of hypoxia. So this is a study that we published, which included 833 patients who went to a surgical floor after non-cardiac surgery, and we're looking at the issue of hypoxia. In this study, patients had a monitor that was collecting blindly data on patients' oxygen saturation, and nurses were told just to measure vitals as they normally did and to respond to them. The nurses indicated that 5% of the patients had an oxygen saturation of less than 90% on the surgical floor. We then looked to see amongst the patients who the nurses said did not have hypoxia, that is the 95% of patients who were participating in the study, what did our continuous oxygen monitor demonstrate? And what it demonstrated was that 38% of these patients who the nurses said were not hypoxic had at least one episode with a SAT less than 90% that lasted for at least 1 hour in continuous duration. 10% of patients had at least one episode of continuous SATs less than 85% lasted for at least 1 hour. When we look at the issue of monitoring for hypotension, a study published from the Cleveland Clinic, Dan Sesler and his group, where they used the Sotera wrist monitoring blood pressure cuff, what they demonstrated was that 312 patients post-abdominal surgery had a median of 48 hours of continuous BP monitoring. Once again, the BP monitoring was being undertaken, and nurses were told to measure vitals as they normally did. Dr. Sesler and his group demonstrated in this study was that 24% of patients had a MAP less than 70% for 30 minutes, and nurses did not detect 21% of these events. And 16% of patients had a MAP less than 70 for at least 60 minutes. 18% of patients had a MAP less than 65 for at least 15 minutes, and nurses did not detect almost 50% of these cases. And the reality is the Cleveland Clinic is an elite center where, in fact, vitals are routinely checked every 4 hours. So in reality, compared to most centers, including my own, this, in fact, would be a very optimistic result. In fact, there's almost for certain longer durations and more patients not being detected. If we look at the issue of suboptimal monitoring at the issue of myocardial ischemia, we have demonstrated in the Vision study that 93% of myocardial injuries after non-cardiac surgery that impact 30-day mortality and impact long-term outcomes. These events occur without ischemic symptoms and likely would go unrecognized without postoperative troponin monitoring. And elevated postoperative high-sensitive troponin T assays without ischemic symptoms have again over a 3-fold increase in the probability of death at 30 days. This just shows you the results of the MANAGE trial, which took patients who had myocardial injury after non-cardiac surgery, MINS, and randomized them to dabigatran versus placebo. And this is just to make the point that, in fact, many of these complications after surgery that are associated with really poor outcomes are likely modifiable. So what we see in this Kaplan-Meier plot is that patients randomized to dabigatran had a 28% relative reduction in the risk of major complications at 2 years. We see that the two curves diverge almost immediately after randomization. They continue to diverge till about 1 year and then remain parallel out to 2 years. But importantly, the risk is not even plateaued at 2 years, and the risk is very substantial in terms of patients in the placebo group having major complications. Looking at the issue of suboptimal monitoring and covert stroke and cognitive decline. We published the results of the Neurovision study last summer in The Lancet. In this study, we included 1,114 representative patients aged 65 or greater who underwent elective major non-cardiac surgery. We did a brain MRI in these patients between day 2 and 9 after surgery. 12 centers participated from 9 countries. 7 of the patients demonstrated a new covert stroke. So using diffusion-weighted imaging, you know that this is a new stroke that happened in the last 10 days. And these covert strokes increase the risk of perioperative delirium over 2-fold, also cognitive decline at 1 year. So 42% of the patients who had a covert stroke had cognitive decline at 1 year, whereas 29% of the patients who did not have a covert stroke had cognitive decline at 1 year. And the 1-year risk of overt stroke or TIA, there was a 4-fold increase in this in the patients who had a covert stroke versus those that didn't have a covert stroke. Again, identifying the point that many complications occur in the perioperative setting which may not be recognized by clinicians initially, but actually have real significant impact on our patients. We also have a reality in the perioperative setting of missed opportunities. So in the VISION study, 18% of patients undergoing non-cardiac surgery were active smokers. The patients told us that 50% of these patients were active smokers, told us they resumed smoking within 30 days and almost immediately after leaving the hospital. Less than 5% of patients globally were offered nicotine replacement therapy prior to surgery, in the hospital, or at the time of hospital discharge. This is an enormous missed opportunity for long-term health. We need to continue intraoperative research, but we need to dramatically increase research outside of the operating room. And we have to have a willingness to change structural issues and be disruptive to really bring us to the next place of making surgery safer. We need to learn from the story of anesthesiology. I believe the potential for the third paradigm shift to improve surgical outcomes will consist of 2 components. One is a new perioperative care service that is dedicated and available to co-manage patients with surgeons after surgery on surgical floors, but also importantly help transition patients into the home setting. And we also need remote automated non-invasive monitoring technology. Smartview is a randomized control trial of 800 patients that we're currently conducting. These are patients who are admitted to the surgical floor after cardiac or vascular surgery, and they are randomized in the intervention group to Philips remote automated monitoring with alerts and monitoring into the home setting, or patients are randomized just to standard care where nurses do vitals on the surgical floor and patients go home without any monitoring. The primary endpoint is hospital readmission or ER visits. In hospital, patients use the Philips monitoring strategy, which does intermittent blood pressure, continuous heart rate, oxygen saturation, and respiratory rate. There are alerts that we built in based on these monitoring results that alert to the nurses, and then the responses that have to happen while the patient's in the hospital. When patients are transferred home, they go home with this technology where they have a tablet where they can interact with the nurses on a daily basis. They have a portable blood pressure cuff machine that can also measure their heart rate. They have a sat monitor, a thermometer, and a scale. The Smartview trial has been put on hold due to COVID. We've randomized just over 500 patients. We're hoping to finish this trial, hopefully when things get moving again post-COVID, in about a 3-month period. Because of COVID, we are undertaking currently the PBCRAM trial. And the background to this trial is that to facilitate physical distancing and reduce the risk of COVID-19 and to maximize bed availability for COVID-19 patients, hospitals cancel elective surgeries. Now, most of our hospitals are starting to resume some of these elective surgeries, but even with resuming elective surgeries, in Ontario alone, there's a backlog of 50,000 surgical cases waiting to be done. So there needs to be a way to handle all of these patients. There are also, even during COVID, there's been a need to keep doing inpatient, semi-urgent oncology, urgent hip fractures, and emergency AAA ruptures types of surgeries. And patients discharged after non-elective surgeries have a 15 to 25% incidence of hospital readmission or emergency department or urgent care center visits. That consumes a lot of hospital capacity that, once again, limits our ability to manage COVID patients, also get our elective surgery list caught up, and also increases the probability of exposure to COVID-19 infection both to patients and to healthcare providers. The primary objective of the PBCRAM trial is to determine in patients being discharged after non-elective surgery the effect of virtual care with RAM technology compared to standard care on days alive at home. This is an investigator-initiated randomized control trial. We're including 900 patients being randomized to virtual care with RAM or being randomized to standard care, and the outcome is adjudicated and blinded. Patients are age 40 or greater being discharged after non-elective surgery. We have 9 centers in Ontario, Alberta, and Nova Scotia participating in this trial. So all patients going home are given a tablet computer and the RAM technology. This is from the company CloudDX. This technology can measure blood pressure, heart rate, respiratory rate, oxygen saturation, temperature, and weight. Patients also do daily recovery surveys. The virtual nurses have a call with the patients on days 1 to 15 and every other day between days 16 and 30 if they're in the intervention arm. This just shows you a picture of the technology we're using in CloudDX study. This is a picture here of the tablet, which gives patients 24 hours a day, 7 days a week, instant access to a nurse and a dedicated perioperative physician and also their surgeon. And this is a wrist blood pressure cuff pulse wave that CloudDX has that's approved by Health Canada and the FDA. And there's a thermometer, and the patients also have an O2 sat and a scale. In the trial, we've already randomized over 500 patients. We are hoping to finish the 900 patients in the next 6 weeks. Where we're ultimately going, though, with our research on remote automated monitoring technology is to continuous non-invasive monitoring. This shows you a device that's been developed by CloudDX, who we're working with for Vision 2. And with this monitor, these patients wear it, which is very comfortable. It's light. It can be worn 24 hours a day. We can get continuous heart rate, heart rhythm, continuous blood pressure, temperature, oxygen saturation, respiratory rate, 5-lead ECG, movement, body position, fall detection, sleep analysis, and steps. And we do believe that it's the continuous monitoring of many biophysical parameters that give us the best potential to identify early patients who are at high risk of getting into trouble. I want to briefly just mention that a year ago, we started a new division at McMaster University of Perioperative Care. This is a multidisciplinary venture, which includes anesthesiology, medicine, nursing, rehab, and surgery. It is both an academic and division and a clinical service. Our clinical services we've now had for over a year in place where patients after cardiac surgery coming out of the ICU are admitted to the cardiac surgery ward under our perioperative care physician team who 7 days a week run that service and manage those patients and cannot be on another service but are available all day long to manage these patients. We're also now just starting this for orthopedic surgery, and we hope to grow this and expand it across all surgical service that want this type of service available. And importantly, we're helping to transition these patients into the home settings. And as we do more and more work with our remote monitoring, using remote monitoring into the home setting and also rapid follow-up clinics as needed. Our goal is to cut perioperative mortality, complications, and readmissions in half in the coming decade. So takeaway messages is that patients undergo surgery for important reasons. We need to improve surgical outcomes to the point where anyone can have surgery. And I believe that that is doable. We need to implement what we know. We need to avoid missed opportunities. And we need to conduct more research. We should learn from the history of anesthesiology and how intraoperative care has so dramatically improved outcomes. And the Division of Perioperative Care and new care model and surgery into the home setting with RAM technology has the potential to become a third paradigm shift to dramatically improve the safety of patients undergoing all types of major surgeries. I thank you very much for your attention, and I hope again that you've greatly enjoyed this conference. Take care.
Top Med Talk.
Nick Majerison here. Thanks for downloading Top Med Talk. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.